Welcome back to our blood gas review. We talked about what a nurse needs to know as far as which values to look at when looking at a gas. We've talked about what some abnormal gases look like, how we define respiratory acidosis and metabolic, etc. So let's talk about compensation, where the pH is normal, but we're still seeing other abnormal values. So compensation is when the metabolic and or respiratory systems are helping the other system get the acid-base balance back. If we think of carbon dioxide as an acid, and so when your carbon dioxide is really high, it's making our blood very acidic, we need to raise our bicarbonate, which is a base, so that we can get our balance back in place. When we talk about that in those premature and sick term babies, when they are first born, they are not going to be able to compensate. So we have to do that for them. So if we look at a preterm infant's first gas and we see our 717, right, which is acidotic, our pH is too low, our 77 is high, and our bicarb is within normal limits, we would say that we have some respiratory acidosis going on here. However, the baby is not going to fix it themselves, so we make some vent changes. Maybe we increase the rate or the pressure, and then we get our next gas. We're getting closer. Our pH is still not quite great, but it's getting better. Our CO2 is getting better, but still not there. And maybe our bicarb is just kind of hanging out doing its thing. Remember, the kidneys are responsible for the changes in your bicarb. They are the primary place where there is retention or excretion of bicarb. And our kidneys, especially in preterm babies, do not come out fully functioning. So we still have some respiratory acidosis. We're going to make some changes. Maybe this time we change the pressure, etc. And then finally, we have a gas where we're getting back into our normal limits that are acceptable in our preterm babies. So this would be considered a normal gas. Now, again, remember, we have these values that we have memorized over time, where we say that a pH is normal when it's between 7.35 and 7.45, where kind of 7.4 is the ideal. I am telling you what I am more likely to see in a NICU over my time and what you are going to see, because I don't want you to see this 7.34 and someone say like, oh, it's a great gas, and you're like, no, it's supposed to be 7.35 to 7.45. We really do accept lower pHs, right? 728, 730, and consider it a pretty normal gas because we are worried about overventilating these babies and contributing to their chronic lung disease. So I really want you to keep that in mind because it probably feels like we're doing something terrible or I'm telling you the wrong numbers, but I'm trying to be realistic in what you are going to be seeing. So let's look at an HIE baby. Again, if a baby has HIE, as we talked about this week, they have taken a major hit to their body, and so their blood gases are not going to be great. Here, again, we have an abnormal pH. Our CO2 is low to normal, but it's probably working on compensating for this bicarb. It is trying to make the blood more acidotic, but here we've got some metabolic acidosis. So often we'll give a fluid bolus for that. Now we have changed our values. This is coming up. It's getting into a better place. It is still low. You can see our CO2 is rising into a better place, as is our bicarb. In these term babies, we may end up giving them a dose of bicarb to fully correct this, that we realize that their bodies aren't able to correct it. This is still metabolic acidosis, but it is improving. And now we are getting to a place where we would consider this gas in a much more normal zone. So this would be our typical pattern if our baby is just progressing along and we are helping them. Let's look at when our body does start compensating. So this is when our pH is normal, but our bicarb or our CO2 remain abnormal. So what's happening in compensated respiratory acidosis? Our pH has returned to normal or near normal. Our CO2 is high, but it's lowering towards normal. So maybe we're at 65 when before we were at 75. And what you're going to see with our bicarb is that it is also high or it's rising. If you look at subsequent gases together, you will see them kind of moving together in that right area. What is interesting with respiratory and compensated respiratory acidosis is that the CO2 and the bicarb are moving in the same direction. So that's going to be true with compensated metabolic acidosis. So metabolic acidosis, we are primarily looking at our bicarb. So our bicarb is low, but we're trying to get it back into the right normal. And our CO2 is also going to be low because it is trying to make the blood more acidotic to compensate for what is going on with the base. Remember, pH is an evaluation of your acid-base balance. So in compensated metabolic acidosis, your bicarb is still probably not in the best zone, but it has improved. And your respiratory is probably in a pretty good, your respiratory component, which is your CO2, is probably in a good place, but on the low end of normal. So let's put the compensation grid. This is tricky because as we are compensating, we are still having our values change. So in respiratory acidosis, we will notice that we still probably have an abnormal pH, but it's working our way towards there. So our CO2 in respiratory acidosis, as we know, our CO2 is high, but it is lowering, but it is still high. And our bicarb is going to be high or rising because it is trying to make the blood more basic. It is putting more of that base to bring down the acid. In respiratory alkalosis, our pH, right, is too high. It's at 7.4, so it's trying to bring it down. So our CO2 is low. So we're trying to drive our CO2 high by also making our bicarb come down. So it's low or lowering. In metabolic acidosis, right, when we talk about metabolic acidosis, we have an issue with our bicarb being too low. So it is low, but rising. It is working on coming up because our CO2 is on the low end or lowering. It is trying to make the blood have this compensation for the amount of bicarb in it. So one thing that a baby in severe metabolic acidosis will do is breathe faster so that they can blow off CO2 in order to make their bicarb rise. We want the bicarb to rise as a compensation. So breathing faster, tachypnea, is a compensatory mechanism of changing metabolic acidosis. If you see a baby who's had metabolic acidosis and is now breathing extremely fast, this is a sign of distress, and we should be looking at what we can be doing to help that baby. They will tire out. So in metabolic acidosis, we want to make our CO2 high, or raise it up. And in order to do that, we are trying to get our bicarb high and bring it down. So that by putting more acid in there, we're going to do that. So it is confusing. I think the easiest way for me to think about this is if I specifically focus on metabolic acidosis and respiratory acidosis. In metabolic acidosis, you're going to see a low CO2 primarily because the baby is breathing in order to drive that bicarb into a safe zone. So the pH is normal, but we are trying to get that in a good place. If you think about respiratory acidosis, oftentimes in those first few days of life, babies cannot handle fixing this on their own because their kidneys are not able to help them, and so we are going to help them. Their CO2 is high, and we need to help make the blood more basic by rising the bicarb. We're just going to look at a few examples here. And so we have, so looking at just a few of these gases here, you can see what we have kind of lined out. I tried to do this to make this video shorter, but because our CO2 is low, but our bicarb isn't quite fixed yet, we would be looking at this as a metabolic problem. Again, here, our CO2 is still slightly out of normal. We would say that this is respiratory. Here, we've got our pH working towards normal, And our bicarb is still terrible. So if you compare the bicarb to this, we are working on partially compensated metabolic acidosis. Again, same here, not great. And of course, when you see our CO2 is still high, but our pH is almost normal, you would see partially compensated respiratory acidosis. The key for me is that you cannot look at gases as an individual and identify if they are compensated. You've got to look at the gas before. I think this is tricky to look at one gas on its own, especially not knowing exactly what the gas was before and what mode of ventilation the baby is on and all of that. But I want you to recognize that we have some pHs that are at normal or near normal with abnormal values still. That is when you see compensation. When your pH is normal and either your bicarb or your CO2 is abnormal.